Thank you so much for agreeing to talk to me. What I really want to do is talk about your background in the field and your views on both campaign effectiveness and also just the changing public view towards health in general. So if we could just start with a brief overview of the career that you've had.
I've been in public health since 1965, and the reason I'm in public health is the Selective Service Act, otherwise known as the draft. When I graduated medical school in 1961, we were in the Vietnam War, and there was an obligatory 2 years service. I applied for a deferment to be able to complete specialty training so I could go into service as an infectious disease internist rather than being a general medical officer, which would have happened if I'd gone in right after internship. And I was assigned to work in the Epidemic Intelligence Service, something I'd never heard of before. My intention was to do my 2 years military obligation in the US Public Health Service, and then return and be a hospital-based infectious disease doc. I got assigned to work in the California State Health Department in Berkeley, California. And the first day I arrived, I walked in the morning, and in the afternoon, I drove out in the state car to go to investigate an outbreak of gastroenteritis in the Central Valley in the city of Madera, where 1 out of every 6 people had diarrhea or nausea and vomiting. They called it the don't knows. You don't know which end to put on the pot. And it turns out that this outbreak was waterborne, and it was caused by the fact that Madera, as most cities in California, did not even chlorinate their public water supply because the water came from deep wells, and that was felt to be virgin water, which it was, except that one of the wells that supplied water to the town was located at the edge of a field that was irrigated with partially treated sewage. And a gopher dug a hole from this field that was irrigated with partially treated sewage and went to a pit where the housing of the well was located. And there was a tube that had a cap on it that was designed to determine how far down the water level was. And when somebody had checked that, they forgot to put the cap back on it. So the gopher dug this tunnel, and the sewage flooded down into the pit. And as it got over the level of the sounding tube, it flowed down into the public water supply and spread from throughout the city. And we did a survey house to house and found that the farther away you were from the well, the less likely you were to get sick, because there were several other wells that also supplied the city. So that was very exciting. And then in rapid succession, I investigated California's first case of human plague in 15 years, 2 cases of anthrax due to part home canned tuna, an outbreak of tuberculosis in the mountains of Northern California. And I spent 5 weeks in Honduras investigating an outbreak of polio and helping organize a vaccination campaign. Well, hey, with a start like that, it's so exciting. How can you turn back? So I never again thought about going back into clinical medicine. But we did want to go overseas. So after a year in California, transferred to the malaria eradication program at CDC and came back to Atlanta for training for nearly a year. And then we went to El Salvador, where I was evaluating US supported malaria programs in a dozen countries in Latin America. Did that for a year and a half. Then for budgetary reasons, the office got closed, and fortunately CDC paid my way to go to Harvard to get an MPH. Did that, and then came back to Atlanta for a year working in viral diseases. Then I was offered a job as the state epidemiologist for the state of New York, based in Albany. So I left CDC and went to New York, spent 5 years there, really enjoyable, doing general epidemiology, STD, immunization, tuberculosis, maternal and child health, family planning, all that stuff, and did that for 5 years. Then moved to Tennessee to the state health department where I was doing much the same thing. And then I was offered the position of director of the immunization program at CDC. So in 1977, we came back to CDC and to Atlanta. I was director of the immunization division for 10 years. Then I was promoted to be center director for the center that included immunizations, STD, HIV prevention, tuberculosis elimination, oral health, and quarantine. I did that for 7.5 years, and then became senior advisor to the director of CDC for a year. And then in 1996, I retired from CDC and went to the task force, at that time, the Task Force for Child Survival and Development, working on immunization registries in the US and with the World Bank on trying to get the bank more involved in supporting immunizations. And I've been with the task force since then, doing a variety of different things, almost always or always involving immunization. And then I retired from the task force nearly 3 years ago, and am now a part-time consultant.
So, over the career that you've had, what do you think has been the biggest change in the way that the public in general views public health?
Well, I think domestically, when I got into the field, people, if they thought of public health, thought of it as health care for the poor. And that's been true for decades. I think particularly now, first with the post 9/11 anthrax scares, then the swine flu or the H1N1 pandemic in 2009, 2010, and now the COVID-19 pandemic, people are beginning to realize what public health really is, and be aware of the fact that it's an important component of the infrastructure of our society. Globally, I think um, public health was viewed, particularly from the Western perspective, as essentially tropical disease control or infectious disease control in developing countries. And I think what's happened over the last few decades is we've gotten away from the notion of international health, which was sort of a semi-colonial kind of a thing where developed countries provided support for developing countries. And we now talk about global health, realizing that um, our country or our countries in the Western world are not isolated, and that something that happens in other countries affects us, just as what affects us affects people in other countries. So I think we've come to a more mutual feeling of public health from what we had, which I think for many years in the international or global health arena was an us them kind of an operation.
When we're looking at the changing views historically and the changing way that people structured campaigns, obviously now there's a push toward integrating campaigns. Why wasn't that as big a deal earlier, or what were the arguments against it historically?
It's been a big deal for a long time.
Mm.
50 years ago, I worked in malaria eradication, which was a categorical program, and there was tension between the malaria program and the general health services. And this then, uh, the malaria program ultimately did not succeed, but smallpox eradication was taken on and it did succeed, another categorical kind of program. And when the smallpox program ended, when smallpox was eradicated, what was called the expanded program on immunization came into being, which also was a targeted program which didn't necessarily fit totally within the general health services, particularly in developing countries. So there's been this tension between categorical and horizontal programs. going back, well, more than 50 years that I'm personally aware of. This then resulted, I think, in some backlash, this tension between the categorical and the horizontal, which led to the Declaration of Alma-Ata in 1970, I can't remember which year, which basically said that the way to health for all was through comprehensive community-based primary care. And that it set the pendulum swinging maybe away from categorical programs and more towards horizontal programs. But then came along a series of different kinds of categorical approaches. We had the polio eradication initiative that started in 1988. And then more recently, we've had efforts to get rid of tuberculosis. We had Merck's donation of Mectizan to treat river blindness. We had a guinea worm eradication program. We then got Pfizer entered in with donations of azithromycin for trachoma. And we've had the development of a plethora of categorical programs, many of which operate nearly independently of the overall health services. And in recent years, many of them have focused on campaign approaches, time-limited, intensive approaches. And this has sort of exacerbated the tension between the horizontal and the vertical, because frankly, from the donor's perspective, it's a lot easier to talk about the fact that I'm eradicating polio, rather than I'm supporting the development of comprehensive primary care. And in the US, this was highlighted by a probably apocryphal story of a congressman who was asked why he kept supporting categorical grant programs instead of block grant programs, in which the health department would get a grant and could use the funds as it wished. And the response was, whoever died of block grant disease, because you can take pride in the fact that you're preventing a death of measles, but how is it as visible as to say, well, I kept the clinics open for an extra hour every day to provide comprehensive care. So there are some incentives to donors to be able to label what their support is going for and to be able to monitor progress, because it's fairly easy to count numbers of doses of vaccines administered or number of cases of measles occurring or prevented. Well, then to continue this evolution, the people have gotten concerned about all of these categorical programs, and there are also there's often some financial tensions as well, because people working in the categorical programs may get incentives or they may get higher salaries. And so the people who are essentially stuck doing the primary care work are looking at these folks who may have newer vehicles to work with, who may be traveling and thereby getting per diems, which is in many countries, per diems may be a major part of the income of a public health worker. Their salaries aren't very good, but if they go out in the field to work, they get a per diem stipend, and many of them stay with family members or friends and pocket the per diem. So this is one of the concerns as we try to integrate things, as to how to be sure that we're not disincentivizing people. Along with all of these categorical programs, there's been a greater move towards trying to achieve health for all. And this has resulted in the redeclaration from a few years ago about primary health care being the way to health for all. I forget the name of the declaration. It's the current name for what used to be Almaty or Alma Ata in Kazakhstan. Then WHO's current plan of work calls for the development of universal health coverage. And the sustainable development goals that have um, uh, been the successor to the Millennium Development Goals talk about the development of integrated health systems. And then um, the Gavi, the Global Alliance for Vaccines and Immunization, their current plan of work calls for greater integration of immunization services into overall healthcare services. So there are a series of factors that are coming together that are calling for integration. And it's also been the case that the Global Polio Eradication Initiative, which has been the largest single purpose program for the last couple of decades, um, their independent monitoring board in their most recent report said that it's time that polio eradication be formally placed within the overall health system because it's been operating in many countries essentially totally independently of the overall health services. Or it may be with polio, as with many of the other campaign approaches, it may take workers from the ongoing health services and take them away from those tasks for short periods, thereby in some ways weakening the development of comprehensive systems. So there's now a lot more talk about integration, and I think a realization also that there are there is waste involved in trying to do all of these things separately, since many of these campaign approaches target the same or similar audiences or populations. They may carry out the same kinds of campaigns with different interventions, but wouldn't it be simpler and more efficient and effective if they shared a number of resources, particularly in the planning as well as in the delivery of the services? And that's in essence where we are now with this whole notion of health campaign effectiveness, maximizing impact, strengthening systems.
When do you think it is beneficial to move something from campaign based to primary healthcare based? Are there certain things that you look for to say, yes, we've achieved these goals and now it can be transferred over? Or is it more case by case basis?
In many ways, it's a case by case basis. I think um, this has been addressed more directly, for example, with in the measles and rubella arena, where there is 5 of the 6 WHO regions have established um, measles elimination, or all 6 have established measles elimination targets, and I believe 5 have established rubella elimination targets. And doing so, achieving this will require that children get 2 doses of vaccine. And the way this has been accomplished over the last 20 years or so has been to try to administer a dose of vaccine to children when they become 1 year of age, and then to have periodic campaigns that will, first of all, one hopes, reach those who were missed by routine vaccination, and secondly, give a second dose to those who got a dose the way they should have. And there was for some time a discussion about how the switch, the introduction of a second dose of measles rubella vaccine into the ordinary schedule, as opposed to these periodic campaigns, should wait until coverage through the routine system achieved at least 80% coverage. So that there was, in that sense, a target, a threshold. But for most things, I think it really is a question of how well this can be done through ongoing services. And some diseases may be seasonal. Like, for example, malaria in many countries is a seasonal problem. And in that sense, it may be that campaigns are a useful long-term approach to be able to deliver the intervention, because it may not, the impact may not last all year. The same is true, for example, of influenza vaccine, that you're trying to provide the vaccine before the flu season rather than after it, because the protection from the vaccine is not that long lasting. So it varies, and that's why when we talk about full integration and partial integration, we talk about how you should consider what things seem to go well together and what don't. If the target population for one campaign is all in the adult population, and for another it's the infant population, those two things don't necessarily mesh well.
The next thing that I want to talk about is the impact of COVID. So, obviously, this has had a huge impact on health campaigns and on primary healthcare systems around the world. So, I would love to know how you see the impact of that, and also if there's been anything similar that you've faced in the past, any sort of similar pandemics, or I know you mentioned like H1N1 and things like that earlier. So, what challenges have you experienced that are close to this?
Nothing quite like it. Quite frankly, I think the number of campaigns that are going on now for different diseases is much greater than it's ever been in the past. And the issue about trying to um, rationalize what we do in campaigns and what we do in ongoing systems, and how we can try to maximize impact and strengthen systems at the same time, that's been underway for a while, and it's been really made more prominent because of the numbers of campaigns that are currently underway. COVID just disrupted everything. It disrupted ongoing services, it disrupted campaigns, it provided a threat and an opportunity. It's a threat to doing what we have been doing, but it's also an opportunity to, as they say, build back better, and to look at how we can try, since we're not going to be able to just pick up where we were once, if this ends. I won't say once it ends, but if it ends. And we're going to have to make some adaptations. And I think the the two big phrases that people use these days are build back better. That is, let's take this opportunity to think through how we can, in fact, maximize impact and strengthen systems at the same time. And the other phrase is leave no one behind. And that's really a rephrasing and a rebalancing, I guess, of emphasis. This is particularly true in the realm of Gavi, the Global Alliance for Vaccines and Immunizations, which is currently providing about $2 billion a year in support to the poorest countries of the world to provide vaccines and make sure that they are not left behind. Um, what the way Gavi has monitored its progress over the years has been the proportion of children who receive 3 doses of DTP vaccine. Just the simple shorthand is DTP3. Now, globally, this level is now above 85%, but it's been pretty stable for the last 10 plus years. And now Gavi has reoriented its emphasis to focus on the 0-dose child, the child who misses everything, not the child who completes everything. And the phrase that's used is leave no one behind. And I think these are two phrases that will probably appear in whatever commentary the leadership team is publishes. I
Uh,
sure hope it does, and I'll try to make sure it's in there.
With all of this, and especially relevant in COVID now, although I think this has been a growing trend over at least the last decade, we've started to see a growing trend against vaccinations of people who don't believe in the vaccinations or who don't believe in the science behind it. Um, how do you think people are going to uh, respond to this or get around this particular obstacle?
This is a major topic of discussion. I keep participate or tuning into webinars on vaccine hesitancy and anti-vaccination and things like that. Um, this has been with us since Jenner first inoculated Jamie Phelps with cowpox back in the late 18th century. Uh, Anti-vaccine feeling has been present since vaccines were introduced. It has gotten worse in recent decades, um, and I think it's hard to know exactly to finger what events there were. I think one important thing occurred in the 1970s when a group of parents in the United Kingdom had children with brain damage, which they ascribed to DTP vaccine. And they formed an association of parents of brain damaged children or DTP damaged children. I don't remember exactly the name. And there was a Scots epidemiologist named Gordon Stewart who claimed that the data showed that DTP vaccine did cause brain damage. They got quite a bit of publicity, and the result was that DTP vaccine coverage in the United Kingdom fell dramatically over the course of about 5 to 8 years. And there was a massive resurgence of diphtheria in the United and excuse me, of pertussis in the United Kingdom. Um, the publicity spread to the US as well. And in the early 80s, I don't remember what year, I think maybe 82, there was a program called DTP Vaccine Roulette, a 1 hour documentary that um, um, the NBC affiliate in Washington, D.C. put on. And um, the producer of the quote documentary, Leah Thompson, um, was very skillful, and she put together a program which showed in your living room children who are hopelessly retarded and constantly having seizures, and which were attributed to the child having received pertussis vaccine. And you couldn't help but be affected by this. And so here's a parent of, whose life has been totally upset by this occurrence. And then cut to some bureaucratic epidemiologist like me saying, actually, the data do not show that pertussis vaccine is associated with the development of autism, of brain damage in this case. It's not very convincing. And the program was um, such a success that one of the people who was watching it was a lawyer working on the staff of a House committee in Washington on the environment, I believe, who called the station to try to find out more. And when he finally got through, they said that the telephone lines were melting down, and because so many people were calling in about this program. And so, thinking quickly, he said, give them my number. And so that led to the development of an organization called Dissatisfied Parents Together, or DPT, um, which has now morphed into the National Vaccine Information Center, which is probably the largest and most effective um, anti-vaccine source around. It used to be, if you entered the term vaccine on a browser, the first thing that would come up would be NVIC, National Vaccine Information Center, which certainly sounds official, but it isn't. And that then led ultimately to the development of the National Childhood Injury Vaccine Compensation Program, Vaccine Injury Compensation Program in the US, because lawsuits against the manufacturers of DTP vaccine began to rise dramatically, and some manufacturers left the market. DTP, or Dissatisfied Parents Together, has continued. Things then got a lot worse in I believe it was 98, when a British pediatrician named Andrew Wakefield published in The Lancet with 9 other authors an article in which he alleged that MMR vaccine was associated with the development of gastrointestinal problems in autistic children and autism. This study was a case series of a very limited number of children. It developed ultimately that he had been paid to do this study by lawyers who were intending to sue for damages. And ultimately, the study was withdrawn, but not for about 10 years. And Wakefield lost his license to practice medicine in the United Kingdom. He then moved to the US and now lives in Austin, Texas, and maintains a fairly large following, still claiming that MMR vaccine causes autism, in spite of the fact that there are now a large number of studies that show that's not the case. So that's part of it. Then there are some religious groups who are opposed to immunization, just because they feel it's God's will if they become ill. There was a massive epidemic of measles in Southern Africa, and specifically Zimbabwe, a decade or so ago, among members of an apostolic church, which led to thousands of deaths due to measles because they rejected measles vaccine. Then there are concerns in Nigeria. The polio eradication effort got suspended for a while because, for political reasons, some people were claiming that oral polio vaccine was contaminated with HIV or with a contraceptive to sterilize recipients. And then also that this was a Western plot, and that the vaccine was not, is it halal? Is that the proper term?
Oh, halal, yeah.
And basically, polio immunization in northern Nigeria was suspended for about a year, with the result being that polio was exported to some 20 countries that had been free of polio for up to 10 years. And Nigeria ended up getting all of their polio vaccine from Indonesia, the world's largest Muslim nation, as a means of assuring that it wasn't being contaminated. The other thing is that parents today have no idea what these diseases are. And for that matter, neither do physicians. Younger physicians have never, in the US, have never seen a case of measles. They've never seen a case of polio. So how motivated can they be to try to ensure that children get the vaccines? It used to be, I took care of patients with polio when I was in training, acute cases. I saw hospitalized cases of measles. I saw people who died of measles. No one who's graduated from medical school in the US in the last 25, 30 years has seen those things.
Wow. And that does make such a huge difference, being able to actually see what you're fighting against.
Mm-hmm.
It really does. It Well, all right. On a happier note, let's talk about some good things that you've seen. So in the past decade or so, there have been a lot of upsets, but there have also been a lot of major innovations, like with new uses for technology, for data tracking. So can you talk about maybe a few things that you've seen that you thought were really great ideas that you hope more people adopt?
Well, one of the things that I've been working on for now more than 25 years, although less recently, has been immunization registries or infant immunization surveillance systems, as they're called, IIS. And now all 50 states in the US have registries. Um, most of them now are populated from birth records so that every child in a geographic area is entered into the registry. And it's a way of keeping track of how many children receive vaccines, when they receive them, and some 90+% of kids in the US are now enrolled in registries, which is a great step forward. Unfortunately, there's still some problems in trying to share information, particularly between states, because state laws may govern the transfer of information. That is being addressed. I'm not up to date with how well things are working now, but it was a really significant problem. So here's a wonderful technology demonstrated, and there's evidence base for this, that it can raise immunization levels. And it could be more widely adopted. And that's actually one of the things that's a, a factor in the global rollout of COVID vaccines. How are we going to keep track of who gets the vaccine? And information systems and PHII at the task force is involved in trying to work on this as well. A couple of other incredible advances are a technique called molecular epidemiology, which is a laboratory ability to sequence the genome of various microorganisms to determine how they relate to one another. So, for example, there are limited numbers of strains of measles virus in the world. And if you see a patient with measles and you can isolate the virus from them, you can have a pretty good idea of where that virus came from. Similarly with polio virus mutates, as most viruses do, at a fairly constant rate. And so if you get two polio viruses that have very similar structures, you can deduce how closely they are related, or how long it's been since one separated from the other. And this has been extraordinarily useful, particularly in polio and measles, but it also is being used increasingly with diseases such as tuberculosis and I think gonorrhea now also.
Wow.
And that's being used with coronavirus as well.
And going back to, you were just talking about the immunization registries. I have been hearing on many calls that some countries are using voter registration databases as a way of tracking immunizations, and that's what their registries are based on. And then they're also turning polling locations and poll workers
Mhm.
into vaccine workers. Is this something that's going to be widespread? Do you think that that's a good idea?
In large measure, I think it depends on how comprehensive the voter registrations are. We've had some indication in this country in the last year that there are concerns about how complete or accurate our own voting records are. Um, it is an approach, but it only works for people who are registered to vote. And for example, in a country such as Myanmar, where the Rohingya uh, were considered non-people or non-citizens, that wouldn't work. They weren't voting. They weren't being allowed to vote. So it would depend on the situation, I think, in the country.
Right. Okay.
Then a couple of other really positive advances to talk about. Well, one of them is the technology that enabled us to have a COVID-19 vaccine in less than a year. And that's only possible because of technologies that have been developed over the course of the last 20, 25 years. The compression of the testing schedule so that, in fact, all three phases of testing of the vaccine were being carried out simultaneously instead of sequentially was a major factor in this. But the technology that enabled the development of these messenger RNA vaccines was not present 30 years ago. And so we could not have done this. We could have compressed the testing, the clinical testing phase, but doing so, compressing it really required the commitment of massive amounts of money to reduce the risk to manufacturers because they were having to build manufacturing facilities without knowing if the vaccine they were planning to manufacture worked. And so the infusion of government funds into supporting that, as well the development of the manufacturing capacity, as well as the guaranteed purchase of the vaccines once produced, uh, really helped motivate, I think, all of the leading candidates, with the exception of, I think Pfizer, which did not accept US government money. And another really positive thing has been the growing realization that as exciting and dramatic as infectious diseases are, they're not the biggest killers. And it's true in developing countries as well as in the industrialized countries that the leading causes of death are non-communicable diseases. And this is a big change from the way things were 80, 100 years ago, where in the developing world, infectious diseases were the leading causes of death. And this is an advance in a lot of ways, but it also is a challenge in that dealing with non-communicable diseases is not as easy as just giving a dose of vaccine. It typically requires repetitive interventions, behavior change, and it's not as easy in some ways as some of our infectious disease control programs are.
Okay, and you had mentioned, I'm just going to go back one topic. You said 30 years ago, the technology was not present to have developed this vaccine in a year. Out of curiosity, 30 years ago, how long would this vaccine production schedule have taken?
Usually on the order of 7 to 10 years,
Wow.
or even longer. Um, I think rubella vaccine was developed and licensed in about 6 years after the original isolation of the virus. And that was considered a really rapid development. And it was because we had a massive epidemic of rubella in the United States and other countries in 1963-64, which resulted in the US alone with some 20,000 infants born with blindness, deafness, heart lesions, other manifestations of congenital rubella syndrome. And the virus seemed to have a cycle of 6 to 9 years of epidemics. So there was great concern that in 69 or 70, there would be another epidemic of rubella. And there was a lot of effort put into, as rapidly as possible, developing the rubella vaccine to try to prevent the next epidemic.
We've got about 10 minutes left. Is there anything else that you would like to say about the coalition's role in advancing people's views on public health or in helping to integrate campaigns?
Well, I think it, it's really encouraging to see something like the coalition. As I mentioned, for decades, there has been um, tension or friction or competition between broader ongoing health services and categorical programs. And I have participated in meetings going back more than 25 years at which there's, please pardon the cat, um, at which there's been discussion about the fact that these categorical programs or campaigns can have positive as well as negative impacts on the ongoing health system, and that we needed to work to try to maximize the synergies and minimize the competitions. He believes the computer is his. Uh, we've been weeping and wailing about this that I've been involved in, as I say, for more than 25 years, but haven't really done much about it. And I think now we have an opportunity, and people's attention is being drawn to the, the necessity to try to better manage and plan these efforts to try to achieve both individual goals as well as develop good health systems. So I'm encouraged, and I hope that we will be successful.
And we are at time. So again, thank you so much for taking the time to talk to me today.
Thanks a lot, Sarah.